So we'll start with the session. This session is on controversies and preferred practice patterns in pediatric cataract management 2023, a case-based learning. There's a keynote address by Dr. Nehal. Dr. Nehal is here? Yeah. Can we have your talk, madam? Can we have your talk first? Yeah. Yes, sir. Yes, correct, sir. Arun Chandra. I'm from Bangalore. Jyoti is coming. She's coming. She's another session. Another 10 minutes she'll be also speaking. So Dr. Nehal will be talking to us about tips in congenital cataract surgery.
It's a great pleasure and honor for me to participate in your meeting, and I'm going to speak about tips in congenital cataract surgery. To start with cataract surgery with IOL implantation. In these children, the aim of surgery is to have exactly 5 millimeter anterior rexus, exactly 4 millimeter posterior rexus, combined with anterior vitrectomy and IOL implantation inside the capsular bag. Or slightly larger, 5.5 anterior rexus, 4.5 posterior rexus, and this is the maximum sizes of the rexes you can have. To start with anterior capsulorhexis, why it should be exactly 5 in order to cover the IOL optic, because the IOL optic is 6 millimeter. If you go for a smaller rexis, it's gonna proceed with a capsular phimosis requiring secondary surgical intervention. How to proceed with anterior capsulorhexis? If you have a total cataract, we can use a trypan blue stain to stain the anterior capsule and then proceed with the 5 millimeter anterior capsulorhexis. But sometimes the morphology of the cataract may allow you to perform the 5 millimeter, for example, the 5 millimeter lamellar opacity. You go to the edge of the lamellar opacity and follow the edge of this opacity. You can go from the side port to continue the anterior rectus. It will be of the desired size. If you have total opacification of the lamellar opacity, you may proceed a little bit outside the lamellar opacity. Still, it will be ideal, a little bit large, but still it is ideal. In cases of double lamellar opacity, sometimes we follow the inner lamellar opacity in order to achieve the desired size. And sometimes in double lamellar opacity, we follow the outside opacity to achieve again the ideal size. Hydrodissection. Hydrodissection is very important in congenital cataract. You proceed underneath the anterior capsule, inject the BSS, and then you proceed with the hydrodelineation, injecting inside the lens like that in order to proceed with a good hydrodelineation to ensure very good and meticulous cortical cleanup. But take care, it is contraindicated in some situations. As for example, if you look at the child here in the right eye, you can see a congenital posterior capsular defect. And here another child, you can see it very well delineated under the microscope. It's a congenital posterior capsular defect. Sometimes the congenital posterior capsular defect is blocked by somewhat clear cortex, and sometimes it is blocked by opacified lens. Here another here, can you see the posterior capsular defect? And another case with a congenital posterior capsular defect. And in these cases, sometimes the congenital cataract is behind the posterior capsular defect. So when you inject, you proceed with a hydrodelineation, you may lose the lens matter into the posterior segment, increasing the risk of inflammation and secondary glaucoma. And sometimes the defect is hidden underneath a total cataract. Here, another case with a total cataract. Look here, it delineates a large posterior capsular defect. So in these cases, you have to look to the morphology very well before proceeding with the cataract surgery. Also, it is contraindicated in a polar opacity with here like an onion pill opacity, it is hiding a small posterior capsular defect. So to conclude in this issue, before proceeding with a congenital cataract, please focus on the posterior capsule. Definitely you will diagnose the posterior capsular defect. Also, hydrodissection is contraindicated when we have a congenital cataract with a congenital cyst, either associated with congenital cataract, but sometimes the cyst actually is isolated with the congenital cataract, but it blocks a posterior capsular defect. It is also contraindicated when you expect here a posterior lenticonus. Why? In order to proceed with a safe and sound surgery. The following step is polishing of the back surface of the anterior capsule. You have to polish the back surface meticulously and carefully until you have a crystal clear capsular bag. Why? Because if you don't polish, fibrosis of the anterior capsule may prevent good visualization of the retina if you need it in the future. And sometimes, years after surgery, lens epithelial cells may grow over the anterior surface of the lens. And sometimes it grows anterior and posterior surface of the lens, necessitating secondary surgical intervention to clear the visual axis again. The following step is posterior capsular axis. Leaving the posterior capsule intact will definitely lead to posterior capsule opacification. So there is no role to leave the posterior capsule ever intact in children. Sometimes YAG laser capsulotomy is not possible, especially when the child is not cooperative. It, in unexperienced hands, may lead to IOL pitting or IOL cracks, and sometimes in uncooperative children, you need to go again for secondary surgery in order to clear the visual axis. What about the size of posterior axis? It should be exactly 4, not less than 4 millimeter. Why? Because when you proceed with a smaller posterior axis, definitely here capsular phimosis will occur, necessitating secondary surgical intervention to clear the visual axis. How to proceed with posterior axis? You go with a cystiotome, you make a hooking of the posterior capsule, tenting, and then more tenting and tearing. It should be a triangular tear. This triangular tear, you can go in with a cannula and you inject the viscoelastic into the burger space. If you want to be sure that you are in a burger space, you're going to see this rounded halo, so this will be very easy to proceed with the posterior capsular axis of the desired size of the 4 millimeter posterior axis. Anterior vitrectomy. Anterior vitrectomy is extremely important in children. Inadequate vitrectomy, what's going to happen? You're going to see the lens epithelial cells will grow over remnants of the anterior vitreous face. Here, a beautiful posterior axis, but inadequate vitrectomy. You can see here with magnification that the lens epithelial cells grow over the remnants of the anterior vitreous face, and sometimes totally occlude the visual axis despite having a posterior axis. And in some cases here, can you see this is the edge of posterior axis, but with inadequate vitrectomy, we had to go again to clear the visual axis. But when we go for an ideal surgery with a good anterior vitrectomy, look here, can you see this is the lens epithelial cells actually respect the edge of posterior capsular axis. Here, the lens epithelial cells follow the edge of posterior capsular axis, and sometimes circumferentially like that. And as years passes by, the lens epithelial cells grow circumferentially here more and more years. This is 5 years after surgery. Lens epithelial cells stop at the edge of posterior capsular axis. And sometimes, even if the posterior capsular axis is small, but with a good anterior vitrectomy, you can have clear visual axis. This eye, 10 years after surgery, small rexes, but with a good vitrectomy, maintaining a clear visual axis. IOL implantation. You can either inject a single piece inside the capsular bag or a multi-piece hydrophobic acrylic lenses inside the capsular bag. Please don't implant PMMA lenses, nor hydrophilic lenses, nor silicon lenses. There is an important tip. In order not to lose the lens inside the posterior chamber, when injecting, look to the lower haptic. It should be exactly underneath the anterior rexis. Then proceed, it's going to be easy. You can push the IOL perfectly like that between the anterior and posterior axes, here before and at conclusion of surgery, before and at conclusion of surgery. This is a triple lamellar opacity before and at conclusion of surgery. After surgery, if you leave the posterior capsule intact, look here, the lens epithelial cells will grow from the equator, and definitely you're going to have this picture one day in this child. But either using a multi-piece or a single piece, can you see the lens epithelial cells grow here from the equator and then proceed forward? They never cross the posterior capsular axis, here extending circumferentially with perfect respect of the posterior capsular axis. Here another case with respect of posterior capsular axis along years. This is 5 years after surgery. They merge and diffuse like that around the posterior capsular axis. Here again, diffuse opacification with beautiful clear visual axis. This is 5 years. This is 5 years after surgery, and this is 10 years after surgery with clear visual axis. But sometimes pearls extend like that in colonies. They start in colonies like that, and still, even these colonies, they increase with time, extensive like that. Here, 2 points with clear visual axis increase by time. Diffuse opacification like that, 3 points, 4 points, 5 years after surgery. Extensive pearls, 10 years after surgery, 10 years after surgery, 20 years after surgery. I did these babies 20 years ago. Yes, extensive pearls, but with clear visual axis. Sometimes there is calcification of the sommering ring. This is 5 years and 10 years after surgery. And here a baby few months after surgery and 20 years after surgery. This is the child 20 years after surgery with calcification of the sommering ring, but clear visual axis. The second part of the talk is the cataract surgery without IOL implant. I exceeded my time. Okay, no need for, I will conclude. I'm really so sorry. I will just conclude.
Your videos and pictures are wonderful. We would definitely like to see that, but unfortunately the program is tightly packed.
I'm really so sorry.
Yeah.
I'll just say a few points. In congenital cataract, you have to go for the babies, if you will not implant, exactly 6 millimeter and exactly 6 millimeter anterior and posterior axis combined with anterior vitrectomy. You're going to see few years after surgery a beautiful capsular support, 5 millimeter, where you can inject the IOL in sulcus. And very important to do polishing in these cases. Why? Even if you're going to go for anterior vitrectomy, because if you don't polish, the sommering ring will be very thick. It will push the IOL forward, leading to secondary glaucoma in the future, and sometimes so thick like that, that you have to remove the sommering ring and you have to enlarge the capsular opening like this at time of secondary IOL implantation. But when you polish, you will have this beautiful fibrotic ring where you can implant the secondary IOL after surgery. And sometimes when you have polishing and thin capsular support and of ideal size, you can implant the IOL and make optic capture technique. And this is optic capture technique, and he's 10 years after optic capture technique. Finally, to conclude, you fit the babies with aphakic spectacles, and these are called ultra-thin high definition. You can reach even 23 diopters in these babies, and still they fit perfectly. So finally, to conclude, when you have a case of congenital cataract, you have to be extensive, meticulously, and careful while dealing with these surgeries in order to perform sound and safe surgeries in these young angels. And sorry for being late, and thank you very much for your kind attention.
Thank you, madam. That was a wonderful presentation. The videos and pictures were amazing. Sir, any comments, sir?
Yeah, I think this was very beautiful presentation, showing video as well as photographic representation.
No.
Now we have with us Dr. Arun, who is the chairman of this session. He will be speaking on when do I implant an IOL? What does current evidence say? Dr. Arun Dr. Jyoti Matalia, they are the chairman of this session, and they are managing this session.
Thank you, sir. It's an honor to have you here with us on the podium, sir. So I'll be discussing about when to implant an IOL in children. It's not moving. It's not moving. Yeah. So currently the options for correcting pediatric FAK is one is the FAK glasses, the contact lenses, and the IOL. IOL has been widely accepted as it gives a superior quality of vision compared to other modalities of correction. So when to implant is a big question. So above 2 years, there is a consensus. Everybody agrees, yes, IOL is safe and everybody is using it. But the problem comes in infants, where still a lot of controversy, a lot of people who are for and against implantation. So what are the benefits of early implantation? One is, especially in unilateral cataracts, IOL is one of the best modalities of rehabilitation of the vision. Otherwise, invariably, they end up with dense amblyopia. The compliance to contact lens, especially in our population, is quite poor, and also the cost of treatment will be quite significant. So that's how the IOL is probably a better modality of rehabilitation. Challenges with early IOL is, one is deciding on the IOL power, because there is a lot of changes in the first 6 months of life, rapid myopic shifts. Intraoperative challenges to get a good rexis. Madam showed wonderful rexis, but to get such a beautiful rexis in an infant is quite a challenge. Higher chances of resurgery, chances of visual axis opacification, and IOL, implanting an IOL also increases the inflammation. So there will be very severe post-op uveitis, higher incidence of glaucoma, and decentration of the IOL and pupillary abnormalities. So to decide which is superior, we look at the visual outcomes, the binocular vision outcome, the complication rate, the resurgery rate, and the cost of the treatment. So what does the evidence say? So one of the earliest treatment, the studies done here is the infant FAK treatment study. So here it compared the implantation of IOL versus FAK with contact lens in the age group 0 to 7 years. So the eyes was randomized into no IOL and IOL group, and the median logMAR visual acuity was not significantly different between the two treatment groups. However, the children in the IOL group had a significantly higher adverse reactions, and especially the visual axis opacification. So invariably they required a resurgery for the visual axis opacification. And most of these patients had more than one surgery. So that's how this IITS concluded that primary IOL was associated with a higher risk of resurgeries, and the visual outcomes was the same in both the groups. Another study is the TAPS study, the toddler aphakia, pseudophakia study. So here it's actually the part of the IITS only, the children in the older age group between 7 months to 24 months. So they were studied, and all of them underwent IOL surgery. 92% of these patients required a primary implantation, and operative complications occurred in only 4 patients. And at the age of 5 years, the visual acuity in treated eyes were very good. And they concluded that IOL implantation is relatively safe in this 7 to 24 month age group. There is another study from Norway where they did a primary IOL implantation in infants with unilateral cataract before the age of 12 weeks. So here again, infants with unilateral cataract before the age of 12 weeks underwent a primary implantation, and 17 eyes had persistent fetal vasculature. So this is another important finding in this study, where they found that unilateral cataracts were associated with a higher incidence of PHPV. So all except one required resurgery for the visual axis opacification, and they concluded that cataract surgery with primary IOL implantation in the age group before 12 years of age resulted in a higher number of visual axis opacifications, and the visual outcome varied considerably, and the coexisting persistent fetal vasculature again contributed to probably the variable visual outcome. And the same group studied the implantation in a bilateral cataract, bilateral congenital cataract, with a median age of 35 days at the age of surgery. And in this study, they found that though all the eyes had visual axis opacification, the outcome was quite good. So primary implantation in bilateral cataract surgery gives a much better outcome compared to a unilateral cataract surgery. And Dr. Jyoti, you can come here. There is another study done in the UK and Ireland, the IOL under 2 study. So this again assessed the outcomes following primary implantation in children aged 2 years and younger with congenital or infantile cataracts. So it was a prospective observational cohort study. A total of 256 children were recruited for the study. You can come. So primary implantation, and they concluded, after the study, they concluded that primary IOL implantation was not associated with a better visual outcome than conventional treatment in children with unilateral or bilateral cataract surgery, and was associated with a 5 times higher risk of resurgery for the visual axis opacification, requiring general anesthesia with bilateral cataract surgery. And in unilateral cataracts, the risk of resurgery was almost 20 times. So they concluded that intraocular implantation does not confer better vision or protection against postoperative glaucoma, and conversely increases the risk of resurgery, requiring repeat general anesthesia for these children. Our own Dr. Vasavada et al. Have studied a 5-year postoperative outcomes of bilateral aphakia, pseudophakia in children up to the age of 2 years. And they concluded that the incidence of postoperative complications was comparable between the 2 groups, except for the higher incidence of posterior synechiae in the pseudophakic groups, and visual rehabilitation was faster in the pseudophakic group. And Dr. Jaspreet Sukija is here with us in the conference today. So they have studied long-term results of primary intraocular implantation in children operated less than 2 years of age for congenital cataract. And they also concluded that primary implantation in children less than 2 years is safe surgical procedure with excellent long-term results. So to summarize, the available literature shows mixed results. Some people are for early surgery, some people say early surgery has no benefit. So most pediatric ophthalmologists now agree that infants of 7 months or older, definitely the IOL implantation is safe and gives a good visual outcomes. But infants younger than 7 months of age, decision is little critical, and it has to be based on case-by-case basis. And especially unilateral cataract, probably the thing will be more in favor of implanting an IOL than not implanting an IOL. And of course, the patient cooperation, the compliance, follow-ups, everything is important. So the minimum criteria required for an IOL implantation, suppose if you are implanting an IOL in a child, either below 7 months or any child, if the white to white is more than 10 millimeters, if the axial length is more than 17 millimeters, if the intraocular pressure is normal, and there are no other associated angle anomalies. So these are the minimum criteria probably which should be met before we can think about implanting a intraocular lens in a child. So to conclude, in a country like ours, primary implantation probably is the best method of visual rehabilitation and the treatment of amblyopia. Cost and compliance will be the main problem with contact lens. And of course, decision should be taken on a case-to-case basis, depending on the other parameters which I mentioned and the parental cooperation. Of course, the refined techniques, newer generation IOL and excellent microscopes we are having with very good red glow, which Madam showed a lot of good pictures. So with that, definitely the consensus is towards earlier implantation of IOL with decreased risk of complications. Thank you. So I'd like to have some points from Dr. Jagatram sir.
Yeah, I think this was excellent presentation, and I agree with him that whatever is recommended, we should do that. We usually implant IOL in 7 months or more, it is safe. But selectively, we implant IOL in younger children, particularly unilateral cataract. Yes. Or I agree with the viewer, what you showed, that if axial length of the globe is 17 millimeter or more, yes, and corneal diameter white to white is 10 millimeter or more, the last slide which you showed. Yes. So there surely I think we can go ahead and implant IOL.
Any questions? Thank you.
Now I'd like to invite Dr. Savleen Kaur from PGI, who would speak on imaging tools for pediatric cataract.
Thank you so much. Good afternoon, everyone. I will be talking about imaging pediatric cataracts and how and when to do it. So pediatric cataracts, as we've already discussed, are very heterogeneous, and in children it is imperative to obtain a complete anterior segment examination before we take the child up for surgery. We want to know what is the status of the anterior and posterior capsule before we can decide the site of intraocular lens implantation. Now, traditionally in adults, we use the slit lamp, and in children, we cannot use that because of the inherent uncooperativeness, and often a complete examination is possible only under anesthesia. So here, imaging can be used as an additional preoperative tool for assessing pediatric cataracts. There are two technologies available, the UBM and the AIOC2023. The ultrasound biomicroscopy, or the UBM, is an ultrasound under high definition and can be a very good technique to image cataracts before you take the child up for surgery. If you do not have a clear cornea also, sometimes you get very good scans and you can see the zonules. You can assess how much is the cataract, what is the morphology of the cataract. The anterior and the posterior capsule give us a higher hypoechoicity, and depending on the thickness and the echo that you obtain from the capsule, a thickness of the capsule can be made out, as well as fibrosis in the anterior or the posterior capsule. Ultrasound can be used to delineate different morphologies of cataracts, and sometimes you just have a white reflex that you see on the slit lamp. You might be using a handheld, but there's no way that you can assess the posterior capsule, so ultrasound comes in handy. When you have membranous cataracts, you're not sure, you see a reduced width of the cataract on the ultrasound, and UBM can also be used to assess how much behind the posterior capsule is and how much you have, how much cataract is there, whether it's involving the posterior capsule or not. Anterior capsular opacities or fibrosis sometimes preclude a good examination, and often children who do not have a very good dilatation, you can do an ultrasound before you take the child up for surgery. In secondary cataracts, the ultrasound comes in is very beneficial. You can see the ciliary body, sometimes you can see the rotation of the iris, and you can make out angle anomalies as well on the ultrasound. The anterior segment OCT is now a non-contact modality which can be used in children. The swept source, again, no financial interest, but is very fast. It takes about 3 seconds to image the child in real time on the AIOC2023. So we did a thesis where we kind of straddled the baby in butterfly position, and we tried to use the AIOC2023 to scan pediatric cataracts in a non-contact way. And because it was very fast, we kind of got some good images to study the morphology of the lens. So normal morphology of a clear lens looks something like this, where you have a hyper-reflective anterior and posterior capsule and the nucleus, and a hypo-reflective cortex. So you can map different types of morphologies of the cataract on the AIOC2023, the zonular cataract being the most common that you see in children, posterior subcapsular cataracts. In total cataracts also, you can get a good reflectivity if you have a clear cornea. Things like persistent hyperplastic vitreous can also be picked up, and again, a reduced anterior-posterior width of the cataract will tell you that it is a membranous cataract. It is beneficial when you suspect posterior lenticonus and you're trying to find out whether there is a defect or not, and you can see the bowing of the posterior capsule without a defect in this case. It comes in handy when you have a white cataract and you directly take the child for surgery. Of course, you can look at the child intraoperatively and then see the findings, but if you have an AIOC2023 preoperatively, you kind of know that there is an anterior capsular fibrosis and a posterior capsular fibrosis, and necessitating the use of vitrector on table so you don't kind of attempt the capsulorhexis, and you can keep your parameters of the phaco machine a little lower. In white cataracts in children, around 2%, you might see a posterior capsular defect as well. It was very nicely delineated. It was very nicely shown in the previous presentation, actually, where the keynote address told us that you have a lot of posterior capsular defects, and you can see as the scan is moving from the nasal to the temporal side, you can actually see the area of dehiscence and how the contents have herniated into the vitreous. So it's a preoperative tool, and you know beforehand, before you take the child up for surgery, then there is a PC defect. Total cataracts, anterior subcapsular cataracts, partially absorbed cataracts, and again cataracts who have anterior capsular ruptures. In select cases of trauma where the cornea is clear, you can get good AIOC2023 scans. It can be used for keratometry in children. Studies have shown that the accuracy goes high up to 80%, but you need to fixate the child, and very small children fixate easily. The bigger ones make it difficult, but if you get a good fixation scan, the accuracy of the keratometer agrees very well with the handheld keratometer or the optical ones that we use in adults. It can be used as a tool to monitor the progression of cataracts. So I'm just showing an example of a child who had a stage 4 ROP and underwent LSV. You can see how the cataract over time has kind of progressed and is increasing, and ASOST was used as a tool to monitor the bilateral cataract that the child had. So in cases where there is a non-dilating pupil in lenticonus, sometimes missed on the slit lamp, you can do the ASOST in these select situations as well. So imaging can help you identify the morphology of cataracts. The posterior capsular integrity can be assessed. Anterior capsular fibrosis can make our capsular access difficult, so it's always good to know if you are suspecting a fibrosis on table. You can be better prepared for using a vitrector and use higher viscosity OVDs. And in short, it will decrease your intraoperative surprises. You can also use these tools for monitoring pediatric cataracts in a country like ours where there's no concept of neonatal screening. So in patients where you require a longitudinal follow-up cataracts, you can use ASOST as well. Every technology comes with its limitations, and they are costly machines. They have a learning curve, and ASOST being optical, ultrasound sometimes fare better in these situations. You use the most sophisticated instrument, but not without a thorough clinical examination. I would like to acknowledge Dr. Jaspreet and a legacy of pediatric cataracts that Dr. Jagatram has left for us. Thank you.
Any questions for Dr. Savlin? That was a wonderful presentation. Thank you. So next we'll go to surgical tips for cataract surgery in pediatric eyes, and we have none other than the pioneer in pediatric cataract surgery, Dr. Jagatram sir.
First of all, I am thankful to Dr. Jyoti Matalia and Dr. Arun for giving me this opportunity to speak on some tips on pediatric cataract surgery. It is an honor for me. While we see these children, they come to us with visually significant cataract. Majority of them, they have bilateral cataract. Almost 10 to 15% of these children, they have unilateral cataract. Picture is like this, only majority of them come very late. But now over the last 42 years, I have seen that now they are coming little early. Now parents are bringing them early. This is, I think, I have collected more than 10,000 photographs over a period of 40 years. And any of the child, while they come to us, we have to dilate. Why we have to dilate? Because we have to document the morphology of cataract. Although there are other digital methods also, as Dr. Savlin has specified, that is fine. But initially we have to dilate to know the exact morphology of cataract, whether it is a zonular cataract or lamellar cataract or PSPV, or whether it is a posterior lenticonus. In addition to that, we have to calculate IOL power. IOL power calculation is important, and there is a issue of increase in the axial length in this growing eye. And so we have to adjust the IOL power. Then we have to take decision whether to implant IOL or not. Dr. Arun already discussed that when we should implant IOL or when we should not, what are the contraindication. Then these children in the post-operative period, they may behave differently. There may be more marked inflammation that you have to manage. And management of amblyopia, these are very, very important issues. Our goal is to achieve a clear visual axis. And here with IOL implantation, and that is also possible in younger children from up to 6 years or sometime up to 8 years, we do primary posterior capsular axis, and then long-term visual rehabilitation. Then I will be showing the, these are the video clips. This is a classical zonular cataract. And to demonstrate, we stain the anterior capsule with the Blurex, trypan blue dye, and do rhexis. as in the, I think, keynote address, Dr. Nihal, she demonstrated very beautifully how we can make continuous curvilinear capsular axis. This is followed by hydrodissection and removal of the cortex from the capsular bag. Our aim is to have almost 5 millimeter of continuous curvilinear capsular axis. Then posterior continuous curvilinear capsular axis or posterior axis, we initiate with needle cystitome, and by and large most of the time we do it with the Utrata forceps. Sometime if it goes out, you can also use vitractor, because it is not 100% time that you may succeed in achieving perfect axis. Here is this anterior continuous curvilinear capsular axis and posterior axis, and then implantation of hydrophobic acrylic IOL in the capsular bag, and you remove any of the vitreous tag. And this is just not femmetor axis, this is a continuous curvilinear capsular axis. And the same patient we demonstrated after while performing the posterior axis. You see the traction, this is not perfect. Actually it is perfect, but there is a traction. So you can use triamcinolone dye and stain this traction. Then you can do vitrectomy, and how this is the final outcome, that you will achieve excellent posterior axis also. So that traction is gone, is the same child. And then the majority of the time we implant IOL in the capsular bag, but sometime we may do optic capture. We may do capture while we place the haptic in the sulcus and optic in the bag, but there is also posterior capture where we implant the optic into the vitreous cavity and haptic in the capsular bag. Here after doing rhexis, hydrodissection and remove the cortical material from the capsular bag. And then we have to do primary posterior capsulotomy. Size of rhexis, posterior rhexis 3.5 to 4 millimeter. And here because we are doing posterior capture of the IOL, so this is posterior capture of the IOL. We have to take care that while doing the posterior capture of the IOL, in that situation it is better to make larger primary posterior capsulotomy. And this is one of the thesis which I gave to resident, and this is to demonstrate whether we can do equally well. This is femmeto second assisted pediatric cataract surgery. So here we have to plan that where we are doing the where we are making the primary incision and where the side port incision, that you have to adjust yourself. And so position of making these anterior and posterior, here is the location, and then finalization, that how long should be the incision. And this is this take almost 1.4 seconds to do rhexis, and then the main incision, and then the side port incision. It is difficult because you have to take the child from one theater where there is your machine is lying to the another, but child is under anesthesia. Here these opening up of these incision. Sometimes it may be difficult, so sometimes you have to use blade. That is the truth I am telling you. It is not 100% sure that you will succeed. So here I am making posterior rhexis. Now IOL implantation into the capsular bag. Okay, this is final. You have to place suture to the main incision, sometime even to the side port incision. This is just to show that long-term follow-up is must for these children having pediatric cataract surgery. This is the child which I operated in 1979, and that time also I did primary posterior capsulotomy and anterior vitrectomy, and this is after 25 years. Child, this boy has done MBBS, and he is having 6/6 vision, although he is myopic, minus 1.5, minus 1.75. He come regularly for follow-up. These are some of the award I think which younger people should get. You people should get it, not me now. And so thank you very much for giving me this opportunity.
Thank you, sir. It's a wonderful presentation. So one small question, sir. If there is a pre-existing dehiscence, Dr. Savleen Kaur has mentioned, the imaging shows there is a dehiscence. So how do you proceed? What precautions you take during the surgery?
Yeah, there is in posterior lenticonus, as very nicely shown, there will be this pre-existing posterior capsular dehiscence. There I think you have to take care that your hydrodissection should be a bit limited, not very forceful, otherwise this lens matter will go into vitreous cavity. So limited hydrodissection, and you should be gentle in aspirating the cortical material, and then we can surely implant IOL into the capsular bag. I don't have in this one because I have that in the complicated other situations, but you can surely implant that you can do vitrectomy in the central zone.
Yes. And another thing is the vitreous jelly is little hard in a child, unlike in an adult. So probably the risk of going inside is little lesser compared to an adult patient. Yes. Thank you, sir. Wonderful presentation.
One question for femtosecond laser. Have you tried doing a PPC, sir, here on the stage, Jyoti? So have you tried doing it with the femtosecond laser?
Yeah, these otherwise it is a double problem. Means that first you are doing the rhexis and other incision in one theater. You are taking the patient to the other theater. It is possible, but you have to do. You have to take again the patient. It is a big problem. So in the patient which I have done 12 patients I did initially, there I have done a manual primary posterior capsulotomy. But otherwise it is possible. But precision with which you have to focus on the posterior capsule is also not so easy.
Yeah, question. Yeah.
I think power is not required because it is a soft.
No, sir. He is asking why femto.
No. Femto is not. That is what I am saying, that it is human can do better than even femto. No, you can do it. It is up to you whether you want to do. It is just to say that you can do equally well. Pemato will do what? Pemato will do, it will make incision. You can also make incision. It is a study. It is not that we are saying that we recommend you that you do Pemato. That is what we are not saying that. Here, that if you have to do, then what you can do, and it will give you perfect rexis. We can do perfect as such also, there is no issue. It is not a recommendation.
Second is, what is your experience with trifocal IOS vis-a-vis amblyopia in children?
In amblyopic eyes, I think we should not use these.
After putting trifocal IOS, do you have experience amblyopia or
That whether amblyopia, because we have used these IOL in bilateral cataract uniformly, and these are the very selectively they are done. So long term outcome still we have to see. The study which we have done, these children 6 years or more in and bilateral cataract, not one eye unilateral cataract, they will be amblyopic. So their outcome is good. Otherwise outcome is good. Almost 2/3 of the children, they had good near and distant visual acuity, but still we have to follow them up for long time.
Thank you, sir. So we'll go with the next talk by Dr. Jyoti Matalia. So she'll be telling about complex situations in pediatric cataract surgery. So as he said, the adult cataract, we are more interested in managing the nucleus. So how do you do the direct chop, dividend conquer, all these things. But in pediatric cataract, it's managing the anterior and the posterior capsules. So that's the difference between adult and pediatric surgeries. And now Dr. Jyoti will tell us more complex situations.
Yes. So before I move on, I just want to answer. So a lot of doctors have a problem doing a pediatric capsular rexis in a child because it's very elastic. It tends to run off. So for their comfort, who somebody feels that they can do femtosecond laser would prefer to take the child because they are not comfortable. Otherwise, somebody who is routinely handling pediatric cataracts, knows it's the style and the trick of doing it, will not want to do a femtosecond laser. Okay, so now I will talk something about the complex pediatric cataract surgeries, tips for success. So one thing very important in any child, we have to have a good vitrectomy machine, a microrexis forceps, and an endolite. Endolite is something I prefer to use basically for novice surgeons when they are not able to see the vitreous. Like with the endo illuminator held obliquely on the limbus, you can easily see the PPC, which is very clear. You can also see the vitreous strands, which are not seen otherwise, because all the time you may not have an access to very good microscopes, very good options. So this can help you pick up, especially in those who are learning. So let me start by showing you some interesting cases. This is a patient who had a large capsular defect, and it's about how to manage a traumatic cataract following corneal tear.
First was a case of absorbed
So as you can see,
following corneal
I
tear.
wanted the volume
After
for this.
releasing the
It's not
synechiae,
playing.
a thorough exploration of the capsular bag showed a wedge.
It's coming slow.
Yeah. I think, can you increase the volume for this?
First was a case of absorbed traumatic cataract following corneal tear. After releasing the synechiae, a thorough exploration of the capsular bag showed a wedge extending over 2 clock hours of absent anterior and posterior capsular support. So after aspirating the cortical matter, the remnant of the anterior and posterior capsules was retained as a support for the IOL, except for the central area to clear the visual axis. That is evident with the endo illuminator. Keeping in mind this capsular defect, a foldable 3-piece IOL was then injected in the sulcus with minimal manipulation to be placed over the leftover scaffold of both the capsules to allow the best stability for the IOL. This is the final position of the IOL with a vision of 6 by 6 parts.
So what you can see, I have not rotated or dialed the lens. You have to try to nudge it in because you cannot dial. This can slip out. There's an area of absent anterior and posterior capsular support. And secondly, remember that if you're putting it in the sulcus, it has to be a 3-piece lens. You cannot put a single piece in the sulcus.
Next case was a membranous absorbed cataract with a PC plaque and a high astigmatism of 5 diopter. A customized toric intraocular lens implantation was planned. Intraoperative 0 to 180 degrees horizontal marking was done. Due to the wrinkling of the anterior capsule, a careful capsular rexis of adequate size was obtained using trypan glue and microrexis forceps and scissors. The PC plaque was carefully removed and an anterior vitrectomy was done in the area of the pre-existing PC dehiscence as is seen here. The endo-illuminator was used for the same. The intraocular lens was implanted in the bag and adjusted along the markings. At the final follow-up, the intraocular lens was nicely in place.
So what you can understand is a smart toric IOL. Smart toric IOLs are IOLs in which the toricity is already incorporated into the IOL. All you have to put it at 0 to 180. That helps, and that is the reason why, because of an existing dehiscence, we prefer to use a plate haptic so that it can go snugly between your anterior and the posterior capsules and stay in place. It will not rotate, so that we can incorporate for the toricity of -5 with this patient.
Next case was a
Okay, and this is now another case of a traumatic subluxated cataract. You can see here that there is a subluxation, and you also see a fibrinous exudation which is there and partial subluxation. So now before you plan to do anything, I would not release this attachments which are there, the fibrin. You can see 120-degree subluxation, the sphincter tear. So you would stain it with trypan blue, and then you start doing your X's. Now in this case, you have to realize to decompress an intumescent cataract, otherwise it can give way. And then once the anterior capsule has become concave, you can go ahead and start a capsular X's. Remember to center it over your lens, not your pupil. Now the membrane is removed gradually and a vitrectomy is done in that area. So you see, after the vitrectomy, be careful that you don't eat up your iris pattern or also the edge of the lens. Then a bimanual irrigation aspiration is done and an CTR is inserted into the bag to inflate it properly. Now in the area of subluxation, you can see a tunnel is made. We use the Gore-Tex sutures to fix the capsular bag with a CTS. You can see that it is passed through the CTS and this segment is then gradually pushed into the bag. You have to ensure that the eyelet comes over your bag so that it is pulled in the direction, and then you tie a Gore-Tex sutures. You have to do this suturing on the scleral wound which is at the maximum proximity of your subluxation. Bury it, and we have also used a fibrin glue to close it. Then you can just put in a single piece hydrophobic lens in the bag, which is like a foldable. Try not to maneuver too much, and you can see it is well placed and the subluxation of the lens is not seen. So this is another case who has come, an international patient who came to me, was operated for cataract about 2 years ago, but you can see there's no evidence of any IOL here. Patient was very sure, the mother, that we have put. So what is this? This is because after having done the cataract surgery, they had not sutured the wound, because of which there's a fibrous ingrowth. Now this ingrowth was already existing, so what do you do in a patient like this? Yes, we made 2 side ports and then tried to separate the synechiae which is there. When you're separating the synechiae, you can see the edge of the lens indicating it's come up. Now it is so adherent, we tried to lift up a flap of the membrane on the anterior capsule and did an anterior membranor in a particular direction to lift it up, and you can see it's completely adherent superiorly. So I did the other side port, put in the same forceps and tried to lift it completely up, which is remained adherent. I try to cut it, it's very, very hard, so I use a vitrector and to make an opening. See the edge of the IOL, you can see inferiorly. And then make 2 openings inferiorly to pass in the iris hook. So what you can understand is area that you want to expose is enough to pass the iris hook. So you don't need to put it superiorly, inferiorly, because you have to go behind the IOL and do a posterior membranectomy. Only the area. Now what is the idea here? We cannot be heroic and try to adjust the lens. We want to clear the visual axis, and that is our primary goal. And hence what we have done, see confirmation with the endolight, you can see the center part is cleared. We have put 2 iris hooks, and because we have not gone full thickness, you don't need to suture those iris hooks. But superiorly, we have also passed the other instruments, and hence we have put it at the same time we have to do suturing for them. So this was a patient who came pre-operatively. Post-operatively, we were able to achieve a clearing of visual axis and the child could start seeing. So in this case, trying to adjust is not going to help the child. We want the clarity in the visual axis, which we have given.
The next case was a mature traumatic cataract following blunt trauma. After releasing the posterior synechiae, a defect in the anterior capsule superonasally that extended to the equator was noted. After adequate staining of the anterior capsule, a good capsular excess was fashioned. Centering over the pupil without incorporating that defect. Thereby, the integrity of the capsular bag was maintained. Routine irrigation and aspiration of the cortical matter was performed carefully, and a foldable 3-piece intraocular lens was implanted away from the capsular tear. This technique allowed implantation in the bag.
So what you can notice is, if you try to open up this particular wedge which was there between the two, you would never be able to put the lens in the bag. By maintaining this small strip that I left back, I could put it in the bag. So remember that when you have, if you are able to maintain anything where the bag integrity stays, you can put the lens in the bag. And that's very important in pediatric cases because there is a sudden elasticity in the bag, the whole thing will open up. So try to, even if it's a small tip, but it's important that if you can maintain the strip, you will be able to put a lens in the bag.
The next case.
So this is another case where there's a patient has undergone a penetrating keratoplasty, there's a graft intact and you are planning to go ahead with the cataract surgery. So prefer to do a scleral tunnel here because you do not want to enter anywhere close to your graft host junction. So we have done in the tunnel as you can see, and side ports again see that your entry does not go close to the graft host junction, and that is very, very important. Stain wherever required, put plenty of viscoelastic in the eye. Again, after staining, because you can understand it's important to stain anytime the cornea can get a little hazy, and it's important to get that contrast. So as you can see, always center your capsular rexus over the pupil so you can measure it of the absolute size. After doing it, we made the other side port. And now the entry you can see is done behind the graft host junction. We don't want that to open up. This is a child, so we have to be careful. Again and again, you cannot put him to another PKP. A good hydrodissection is then done, and then the surgery remains routine. Remember not to have the bottle height low. We don't want too much turbulence in the eye. And then a lens is put in. Remember to suture all your side ports and the main port. This is very important because they can open up shear by the presence of the graft, and try to have less fluctuation in the anterior chamber and a less flow of fluid so that your endothelium doesn't get decompensated. Finally, about the management of posterior capsular anomalies. One is persistent fetal vasculature. So if you can see, this is a microcornea with a microchoria, small pupil. So we've used the iris hooks here. Now you can see the blood within the center part indicating the persistent fetal vasculature. A small rexus is then fashioned. We need to have a small one. And remember, the superior side ports are allowing both instruments at the same time. So you don't need to make any extra side ports to allow the instruments to enter in. Here we are not trying to do a PPC, but using the vitrector directly to do a posterior capsulectomy to remove any special tug onto your, if there is a persistent hyaloid artery or anything. A quick short surgery to clean the visual axis by doing a good PPC and removing the thickening behind is done gradually. And thereafter, suturing is very, very mandatory whenever required. Please don't decide not to do it because as you saw the previous case, there's a fibrous ingrowth which is there. Since the other side ports were small, I do not go fully to allow just iris hooks to go. You don't need to suture them. Finally, this is a case of a mature cataract with posterior lenticonus and PC dehiscence.
The last case is a mature intumescent cataract with posterior lenticonus and a pre-existing posterior capsular dehiscence as seen here on pentacam.
A small-sized capsular rexus was fashioned to allow sulcus fixation of the IOL if need be. Hydrodissection was deferred in view of the pre-existing PC dehiscence to prevent sudden giveaway of the posterior capsule. An anterior chamber maintainer was used to prevent the fluctuations in the anterior chamber. Anterior vitrectomy was done in the area of the PC defect. Intraocular lens was then implanted in the sulcus, followed by an optic capture for a good centration. So in this case, if there's already an existing one which is large, you can see there's an also opacification of the vitreous phase. What we can do is first you implant the lens in the bag, as you can see, and thereafter do an anterior vitrectomy to clear the area. So you're ensuring that the lens is in the bag. So this is the other technique where the IOL is first put inside and then you do a vitrectomy. So I hope you've got sufficient tips about how you should be handling complex cases. There's a good part about pediatric cataract that you don't, no two cases are same. Each of them is a different case and you keep on learning as and when you keep on operating. Thank you very much.
Wonderful presentation, Dr. Jyoti. The staining is very, very important in pediatric cataract because it not only improves the visibility, it alters the texture of the capsule. So the rexus becomes much easier after the staining. So I next invite Dr. Varshini Shankar. Dr. Varshini is here? Dr. Varshini? No, I think she's not there. Dr. Aloka? I think both of them are not there. So I think we can take questions now. So in pediatric cataract surgery, as I told you, the management of the capsule is the most important. So managing the anterior rexus and the posterior rexus, because both are quite difficult unless you practice, because they're very, very elastic and it immediately tends to run away. So doing the rexus is actually the most difficult part of a pediatric rexus. And as far as the posterior rexis is concerned, if you're not very confident and you're a beginner, what you can do is you can just implant the lens and then go with the anterior vitrector. So directly with the vitrectomy itself, we can do a posterior capsulotomy and then do a anterior vitrectomy. So that gives you more confidence that the lens will not go inside, and you can do a very limited rexis, whatever the size you intend to do it. Sir, any comments, sir? We have time.
I agree with you. In children, we have to stain the anterior capsule. That is possible by trypan blue dye. And after staining, it gives you more confidence, particularly younger people in the audience. It will give you more confidence that what should be the size of the rexis, what is the precision, and you can also monitor your force that it is not going. You will be much more. You will know it much earlier, particularly for anterior. For posterior, of course. I don't do staining for posterior rexis of the posterior capsule.
Capsule, not necessary.
I make a small nick with the needle cystitome, elevate the posterior capsule and regulate the forces, and make it approximately 3.5 to 4 millimeters.
So for the beginner, that fear that the lens, as madam showed that video, lens might go inside, that fear will be there because when you do the posterior rexis and implant the lens after
means
the
lens will go posteriorly. But if it is 3.5 or so,
it's less.
You can direct, and a single piece IOL can easily be placed in the bag, capsular bag.
Correct.
Then 3 piece IOL.
Yes.
If it is your rexis anterior and posterior are perfect,
yes.
you can easily place a single piece IOL in the bag. But 3 piece IOL, I think your direction is very, very important, that they have to be directed to the bag. And they may not, if it is posterior, then you may.
Correct.
So just to add here that normally when you're putting a lens in the bag, you direct it because you have an intact posterior capsule, you will just direct the lens towards the posterior capsule you put in. But when you have an opening already, you know that's an area of weakening of your posterior capsule. So always aim it towards your anterior capsule, toward the equator. So whenever you go in, you cannot go like this, a little up. So as you go in, you let your first the haptic-optic junction come out, then your haptic comes in. Now you have ensured it's between your anterior and the posterior capsule. It's away from your entering of the PPC. Then you slowly push in. These foldable lenses open up very slowly. So there's no hurry. You don't have to push in. Do very gradually, but aim upwards towards your anterior capsule or your equator. And as it opens up, keep watching your PC. At no time you should see your PC distorted. If your posterior capsule is already getting distorted, you know that your lens has started dipping in. So when your direction is upwards, your haptic-optic junction is gone under your anterior capsule, the aptic starts opening up, and you're ensuring that your entire lens is above your PC. So make sure that you follow this.
Sir, you had a question, sir?
To what age you will go ahead with the primary posterior capsule?
I do up to 6 years surely, but if I know that the compliance will be poor, then even up to 8 years. Because even after 6 years it will opacify, but most of the time up to 8 years of age I do primary posterior capsule.
If you feel the child can sit and get a YAG done, you can wait. But if there's a mentally challenged child, you feel the child is not cooperative, there are a lot of issues which make you feel that this child will not come back for a YAG cap, or is not suitable, or is not going to be done, then you can do a PPC.
The other problem is the pediatric PCOs. They are very fibrous. So you need lot of power from the YAG laser to make that opening. So in fact, I would prefer that even up to the age of 8 or 9 years, we definitely do a PPC so that we don't end up using a lot of power YAG laser onto the capsule, because they tend to be very fibrous and you cannot penetrate that many a times.
Nowadays we are getting patients who are doing operating cap, nothing like that, and it's a very thick posterior capsule. So many times we have to go to the past planar.
Yes. Yes, sir. So that's the message to all the postgraduates here. Never attempt a pediatric cataract surgery if you don't have an anterior vitrectomy machine. Anterior vitrectomy is whatever comes with a phaco machine, that is enough. That is enough to do a good anterior vitrectomy. But if you don't have an anterior vitrectomy, please don't do a pediatric cataract, because you will end up making the opacity, suppose if the opacity is 50%, you will end up making it 100% if you don't do a anterior vitrectomy and a posterior capsulotomy. So without anterior vitrectomy, I think it is a crime to do a pediatric cataract surgery.
Sir, I just want to ask you, how many IOL exchange you are
Yeah, IOL exchange, I have done a lot of IOL exchange. Those patients which I have operated about 35, 40 years back. Now, not all of them, but maybe one patient out of 100 or sometimes two patient, because they have gone into that myopic shift. They were minus, not all, but I think very few of them, few dozen I have done. So that's why when it was not known, Dahan's guidelines were also not there. In 1997, this paper was published, Dahan's guidelines, in Journal of Cataract and Refractive Surgery. After that, we followed that. Before that, it was not known, although we used to do under correction.
In such cases, we prefer to do with lens. By that time, we attain that much of age. The IOL is remaining there for
Yes.
20 years.
Yes.
Fibrosis,
It's very difficult to explant. Yes.
no doubt it's a costly affair, but I
Yes.
think
It's definitely, sir. It is more traumatic to remove the lens and put another lens, and the piggyback is probably yes.
like
Yes.
you
Yes.
can do it very well.
Yes. Yes.
For us, piggyback lens is the option. I'm just asking.
Definitely yes.
I think
Definitely,
it
yes.
depends that if the power of the lens is adjustable with the piggyback IOL, because even minus lenses, they are not available up to, it is available 5, 7 diopter. Not some of the powers are not available, high power. So that you have to make judgment whether it is a piggyback IOL is a better option. If it is within that range, then it is fine. Otherwise, you have to do IOL exchange. You have to remove the IOL from the capsular bag and implant another IOL.
Madam. Yes. Yeah. Should we use triamcinolone acetate for anterior vitrectomy in every case?
Not 100% time I use triamcinolone.
Not
Like
really
in my
necessary.
practice, I don't use at
we
all.
don't use
As
at
I
all.
showed,
Only when there is a doubt,
can
we can use it, because again that is known to cause increase in the intraocular pressure. So using tricot also, you should be very careful. You should not go too much inside. Only the upper anterior chamber, you just need to put it and ensure that you remove the whole this thing tricot before closing. Yeah.
And as I mentioned, that endo light which you have, it's a normal illuminating light which you have a particular probe, just like they would use in endo light, but you don't need to go inside. You just put it on the limbus, and the tangential light that comes in can show you the vitreous which is there. So that's something which is just available as a separate pack. You may not get it. It could be also a part of your phaco machine that's there, but that's very comfortable for people initially who want to just ensure that it is there. It just not only helps you delineate your vitreous strands, but also your PPC, whether it's off site, where it is there, especially if you're, because in pediatric cataract sometimes the pupil becomes small, there is a lot of haze that comes in. So at least those all things can be clear and you can see a clear PPC. So those are the advantages of having that, where you're not putting anything inside, but you're using it outside to detect.
Yeah, another thing is where you have done primary posterior capsulotomy and there is a distortion of the, as I showed in one of the picture, and you are trying that you are doing a vitrectomy. You know that there is a traction, you are doing vitrectomy, where you could not make it perfectly fine. There little triamcinolone and it will stain those tags. So selectively I use, not in every case. I don't use in every case.
What's the dilution? Adult we use 1:3. Children dilution should be more.
Dilution of the tricot. Do you
Dilution
dilute it
of
or use it as it is?
Yeah, that is diluted. I think same. Yeah.
What about children? Do you use
Yeah, almost same. We have to dilute it.
Yeah, you can.
IOL formula of choice. Which IOL formula is the best for pediatric?
I think IOL formula, whether over a period of time what we have used, truthfully I will tell you. Initially we used to use SRK2 formula. We were not knowing about other formula. Then came SRKT formula. Then came this Barrett. So that time initially it gives almost same result. Even a study from Dr. M.E. Wilson, he has studied those four formula, and outcome is almost same with every one of them, but accuracy is better Retrospectively also, initially we used SRK2, but then SRKT was much more accurate. Now people use even as Barrett also. So I think it is almost same, but under correction you have to understand how much to do.
So I prefer to use SRKT even now. Yes. But as I said, you have to think about how much to undercorrect. That's important. Multiple factors. Yes, you can use any of these formulas which are there, NADs, which follows the N equal to 7. Depending on the age, you subtract it from 7. But you have to look at the child. What time the child is, what is the age of the child? What are the possibilities, risk of amblyopia? He comes from a low socioeconomic status. You know this patient may not wear glasses. Then you cannot undercorrect it as much. Then less undercorrect. Look at the other eye. If both eyes have cataract, it's unilateral or not. If it's unilateral, the other eye is already myopic, you can keep him in unilateral. If the other eye is significantly hyperopic, you can undercorrect more. So there are a lot of things. It's not like one thing. You have to look at the whole thing. Parents are myopic. You know this child could go. So there are multiple things. So I would not say, okay, yes. But there are multiple formulas which can use as a guideline and then decide. Try to undercorrect till at least about 6 to 7 years of age so that you have about 5% undercorrection the older it is. When we talk about putting an IOL in a child under 1 year, yes, ideal. In people who are practicing purely pediatric ophthalmology and have a lot of years of experience, yes. But as a novice surgeon, I would say, yes, please wait. At least 1 year, there is no harm. People who are faking and you give a good contact lens or a faking glasses do much better than putting an IOL and having issues related to it. Because if the eyes are small, the reaction is very high. Within less than 1 year, the pupil starts becoming small. You start panicking. So we don't want these things. Keep them a faking, and if need be, you can do an early secondary eye implantation. So unless you're confident of what you can handle and what's comfortable to you, please don't go and do, because I've seen children's eyes butchered and come back. So that's the last thing we want. The idea is to clear the visual axis. So we should do something where the child finally benefits, not us.
Yes, sir. No, sir. Unless you're doing an FE, you leave the child FE. It's not necessary. If you're putting an implant, I don't think it is necessary. I don't do it as a routine.
I do it if there is a case of uveitic cataract, very significant, where I will do about 2 PIs required because there is a possibility of reaction coming in and developing a iris bombay. So in those cases only I do a PI.
Yes, sir. Yes.
It is very true. Those patients with JIA, juvenile idiopathic arthritis and uveitis and recurrent uveitis. In children, it happens very common. There we like to do peripheral irectomy. Otherwise, not routinely.
Routinely not necessary. In fact, it increases the inflammation when you try to do an iridectomy. Yes, sir. Scleral fixation lenses, definitely long-term results are not very good with pediatric patients. Invariably, the sutures they give way. Regarding the iris claw lens, I have no personal experience. I don't know how safe it is.
Iris claw lens.
I don't have any experience of iris claw lens in these children, but I do transcleral fixation of IOL, not before 4 years of age.
So ideally there are a lot of options, but what I would say is if it's a traumatic subluxation, yes, you can go ahead and do any subluxation like what I showed, CTR, CTS, because you know that subluxation is not going to be progressive. But in cases where you're suspecting like a Marfan's or something, I would advise go ahead, I would do a phakia. You can put in a secondary eye once the child is older. Yes, there are a lot of papers who talk about putting it at 7 years, 8 years, 10 years. But what about the child who's going to live 60 years? So better, the later, the better. In that time, you can definitely give an aphakic glasses. There are options of contact glasses that you can give. But once the child is older, you can do a permanent lens. I believe that older the patient, better to do a permanent lens. Iris claw lens works very well, especially the posterior eyelid law. But in a child who is going to be playing outdoors, a little trauma and that can drop in. So why not wait? Aphakic glasses do well. Anyway, it's a replacement for aphakia. Why do it as a primary implantation? Once child is over 20 years, then add a lot of options are there. You can definitely try any of them.
Especially in subluxated lens, it causes a lot of high refractive errors, high myopic astigmatism. So just removing the lens and giving the aphakic correction gives excellent results in those children. And in my experience, the scleral fixation has been very bad. I've had a lot of patients where that suture gave way and the lens drop was there. We had to explant it.
Dr. Nehal wants to ask a question.
Yeah, yes, madam.
Dr. Nehal.
Yes.
Performing the cataract surgery for 28 years now. And,
Would you like to come up? Yeah, sure.
I've been working in pediatric cataract surgery for the past 28 years, and I've been using the Artisan iris claw lens for more than 13 years. We have wonderful results in these cases. I've been implanting it in the anterior chamber and in the posterior chamber, and the conclusion that the anterior chamber IOL is more than perfect. I used to perform along the past 13 years specular microscopy every 6 months. It is more than perfect. The decline is just nil. Concerning the PC Artisan, the only problem is that when the child is actually had any trauma to the eye, it may dislocate into the posterior segment. But the anterior one and the anterior chamber, it is very easy to re-enclavate it again. We had a myopic shift. It was very easy to exchange it. But in cases of suturing the IOL, I used to perform this 23 years ago. I had a myopic shift that I couldn't know what to do. You cannot get the IOL that you sutured into the sclera out easily. But when you perform a beautiful cataract surgery, anterior posterior axis without optic capture technique, and a very good anterior vitrectomy, as I showed you the photos along the past 20 and even 23 years, you can explant it easily and even re-implant again inside the capsular bag for IOL exchange. Thank you.
Wonderful. Thank you, madam. Any other questions? Yes, sir. Sorry, sir, I didn't get the question.
For that, you have to ensure that your aspiration rate should be low. Your cutting should go up to 1,000 to 2,000, but your aspiration should be only 80. I mean, I'm talking about the vacuum, should not be more than 80. The idea of doing anterior vitrectomy in a child is just to remove the part just behind your posterior capsule. So all you do is only that much. When you start having an aspiration of your vacuum of more than 150, you are actually pulling up the central vitreous, which we don't want. So anything about 80 is required. So when you're not pulling in too much and your cutting is higher, you just cut the part which is right around your PPC. So you will not have vitreous coming out. Also, the direction of the port, your irrigation port, should not be downward. So you're trying to infuse your vitreous and more of them coming. Try to keep it more horizontal, so more vitreous doesn't come out. And check your port whether it's working well or not.
Irrigation can be reduced, and just do a shallow anterior vitrectomy only in that area where you have done the posterior capsulotomy. Yes, madam. Yes, madam. Yeah. Pulling it, yes, aspect.
Yeah.
I think we'll take one last question. Yeah.
Under correction, is there a consensus like which formula is which
Under correction of the IOL power.
Different people do different. People who are finding they have been starting with a particular formula, but over time have refined, and depending on how their children or how their patients are doing, they keep doing. So there are multiple. You can start having one which is more standardized or whom you have learned from, and then try to modify depending on because each pediatric ophthalmologist uses their particular undercorrection which he feels works best in his hands.
Yes, madam. No, no, no. That's what I told you, the minimum criteria. Corneal white to white should be more than 10 millimeters, axial length more than 17 millimeters. If that criteria is not met, definitely no intraocular lens, because you will end up with glaucoma and other serious complications and cause more harm to the child than doing good.
But once a child is older, if you're planning to do at that age, there are certain already ready customized small diameter IOLs already available by Orolab. I have no financial disclosure in this. There is a 10.25 overall diameter lens already available, which are 5.5 optic size. That's available. So if your cornea is about 9.5, when you want to plan the secondary IOL, you can think of this. These are rigid IOLs, not foldable. You can think. However, there are certain companies who also customize, but anything less than 10 or becomes difficult. If you want to put 11.5 small customization, it should be always 1 millimeter more than your corneal horizontal corneal diameter. So whatever you get, add 1 to it. That much of customization you can do. There are certain, they are doing it, but these are again non-foldable and they are rigid lens.
I also agree with both of them, because any microcornea or microophthalmos, we should leave them aphakic. And later on we can implant sometime after 3-4 years. Axial length increases and corneal diameter will increase much less.
Yeah. Yes, sir. Sir, no question is silly, sir, please. So we use a handheld keratometer. If the child is cooperating, we do it with the child awake itself. If the child is really not cooperative, then probably under general anesthesia it has to be done, sir.
No, it's a
No,
keratometer.
handheld keratometer and the ultrasound. This thing, you don't do an optical biometry is not possible. Yes, you do an ultrasound axial length measurement. Sorry, sir. It will not be possible, sir. Young children, definitely it will not be possible. That is possible only in cooperative children, maybe 5 years or 6 years.
It is possible, those cooperative children, even 3-4 year children, many of them are cooperative. But this is not the silly, this is the best person. And it is most difficult to answer also.
So I think we are almost there. We'll end the session. I sincerely thank Professor Jagatram sir for joining us on this chair, and Dr. Jyoti for co-chairing, and all the delegates for the wonderful session. Thank you. And Dr. Nihal, our guest speaker. Thank you. Wonderful presentation. Your videos are amazing. Thank you.